Hello everyone, and welcome to the Role of Healthcare Providers in Return to Work After Injury webinar with Dr. Agnieszka Kosny. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is made possible through the support of the Community Grants Program through the BC Government, as well as through donations and memberships to our organization. And as I mentioned, my name is Tanya, and I'm moderating the session and handling the Q&A. And our speaker today is Agnieszka Kosny. Dr. Kosny is a scientist at the Institute for Work and Health in Toronto. She holds a PhD in public health from the University of Toronto and has over 15 years of experience in using qualitative research methods to explore occupational health and safety and workers' compensation issues. We're very glad to have you here today with us, Agnieszka, so I will hand it over to you.
Thank you. Tanya, just one question. Your voice is very, very loud. Is that, can I turn that down in my computer or no?
I will just turn my own sound down a little bit and move my microphone away.
Thank you. Okay, thank you. Welcome, everyone. I'm very pleased to present this, this study that we have just very, very recently finished. And for the purposes of this presentation, I'm going to specifically talk about the role of healthcare providers and in the workers' compensation system, and specifically the challenge of complex conditions. So I'll just get right into it. Oh dear.
Agnieszka, just click on your PowerPoint in the middle somewhere.
Okay.
And then you should work. There you go.
Okay. So this was a 2-year study in 4 provinces examining the role of healthcare providers in workers' compensation systems and in return to work after injury. The study had broadly 3 questions. So the first one was, what is the role of healthcare providers in workers' compensation and in the return to work process? What challenges do they face while in these roles and in helping workers get back to work? And in what ways can we engage healthcare providers in this process? And for the purposes of this presentation, I'm going to focus mostly on number 2 and the challenges that healthcare providers face. So the study consisted of 3 parts. The first part was a document analysis of materials aimed at healthcare providers about their role in return to work and in the compensation process. So these were materials, websites, guidelines published and aimed at healthcare providers. The second were interviews with healthcare providers examining their experiences with the workers' compensation system and return to work. And finally, we also did interviews with case managers about how they interact with healthcare providers and how they view the healthcare provider role in return to work. So we conducted interviews in British Columbia, Manitoba, Ontario, and Newfoundland and Labrador. And I just want to note that for the case manager interviews, we predominantly did those interviews in Manitoba and in BC. We did do some interviews in Ontario, but they were former case managers, and they were also case managers that identified themselves to us as working within organizations. So they were managing return to work, but within particular companies. So they were a little bit of a different group. When we were looking for people to interview, we really tried to get a nice mix of people from large and small urban settings and also rural areas. As well as a mix of specialties, GPs, and in the end of the project we also interviewed some allied healthcare providers, so that would include OTs, physiotherapists, and we wanted to speak to people who had high and low volume of workers' compensation patients, so that they had different levels of contact with the board, Workers' Compensation Board. And one of the criteria for participating, however, is that they had to have experience treating injured workers within the last year of the interview. So this gives you just a snapshot of how many people we interviewed and who they were. So 131 people, and like I said, general practitioners, including family doctors and some practitioners in walk-in clinics, allied healthcare providers, and specialists, and then, like I said, some case managers as well. Just a little bit more about the sample. About 40% of the healthcare providers and 38% of the case managers were women, and most of the healthcare providers came from Ontario, although there was a nice mix. We also found that many of the participants we interviewed had more than one work role or had previous experience working in another kind of position. So this makes it a little bit difficult to talk about the sample because often we would get somebody who said, "Oh, I'm a GP, but I used to work at a walk-in clinic," or somebody who might have been a GP but now is specializing in occupational health. And while it's sort of difficult to describe the variation of experiences that people had, I do feel like it provided us with a lot of different perspectives on on return to work and on working within and with patients who are within the workers' compensation system. We interviewed about half of our sample were healthcare providers who were quite experienced, so more than 15 years of experience. But we also wanted to speak to people who were new to new healthcare providers. So about 20% had less than 5 years. They were less than 5 years in practice, and we also included some residents as well in that number. And then, like I said, none of the case managers that we interviewed were from Newfoundland, and the ones from Ontario were some of them were employed by these private organizations, although some of them were former Workers' Compensation Board adjudicators. So WCB just stands for Workers' Compensation Board. Oh, I should also note, if there's a question of clarification around maybe a term I'm using or an acronym, just maybe type that to Tanya and I can clarify so we don't go through the whole presentation with people not knowing what an acronym stands for. I'll try to explain what everything stands for.
I did just have one quick clarification. There was someone wondering if RMTs were involved, massage therapists?
Yes, I think we had a couple, yeah.
Okay.
Probably a few, maybe one or two. So we don't describe in very specific details about, we had this many physiotherapists or this many massage therapists because we really want to protect people's confidentiality. So we've sort of grouped them by, kind of general practitioners and specialists and allied healthcare providers. So in terms of recruitment, we recruited healthcare providers through professional networks, medical associations, message boards, through social media, and in BC and in Manitoba only, the WCBs also helped us with some recruitment, so obviously recruiting their case managers, but also recruiting some healthcare providers as well. The interviews were conducted in person or in telephone or by telephone if that was preferred, and in some cases if people were in very rural areas and we couldn't fly out there, they were also conducted by telephone. They were recorded and transcribed, and we used in vivo to organize our data, which is a qualitative software. Transcripts were reviewed by the researchers, and we developed a code list, and then data was coded and organized thematically. And we used an inductive approach, which what I mean by that is that we didn't come to the study with some predetermined themes that we wanted to explore, but rather our themes sort of came from the data kind of organically. But of course, we were also sensitive to our key research questions, which I briefly talked about at the start. And we also paid attention to things like contradictions between healthcare providers and any sort of provincial differences, and also differences between the views of healthcare providers and the case managers that we interviewed. Okay, so I will just now get straight into the findings. So what we found was that when injuries are straightforward, things seem to go well, for the most part. So what I mean by that is when patients have a visible, acute physical injury that is clearly work-related and supported by definitive, objective evidence, things usually go pretty well. And what I mean by that is, so the forms in those circumstances seem to be adequate, as is the contact with the level of contact with the WCB, so the level of contact and the type of contact, so via forms and so on. The remuneration seems to be okay, and the healthcare provider's system knowledge is adequate when it comes to these sort of straightforward physical injuries. And in many cases, with these sorts of injuries also, the return to work process is relatively straightforward, we were told. So this is one healthcare provider described. I mean, mostly it's just a simple injury, like someone burnt themselves at work or someone, you know, hurts themselves and they get better and they go back. Those things go smoothly. So the challenges really arose when healthcare providers treated patients who had multiple injuries, had injuries that had a gradual onset, or complex injuries. And some of those were concussions, certain MSK injuries, chronic pain, and mental health. And so I'm really going to focus on their experience working with that group of that group of patients. So one of the issues that came up was that there was a misaligned perspectives on the timing and appropriateness of return to work. The case managers we interviewed tended to view return to work as being uniformly good in virtually all circumstances, and there's really an encouragement and a push to get people back to work as early as possible, and work was really viewed as an extension of the rehabilitation process. And here's how a case manager described it. I always want to know what is the next step. So we are at 4 hours. Can we go to 6 after 2 weeks? We are at 8 after. Are we at 8 after 2 weeks? Can I go 5 pounds to 15 to 30 pounds? So there is that natural progression of improvement, and they're also maximizing their return to work. I look at a return to work as not so much as an employment program, but an extension of your rehab program. So basically, you're going to work to exercise. Healthcare providers, on the other hand, tended to have a more nuanced view of the return to work. And I want to stress that almost everyone we spoke to was very supportive of return to work. They thought in most cases return to work was a good thing for their patients. However, they did feel that early return to work was not always appropriate and in fact could delay recovery in the long run. And so here's how one specialist described it from Manitoba. There's a real mismatch between the clinical picture from the standpoint of the treating physician to what the board deems acceptable. And I feel that they remove themselves from the realities of many workers that do not recover well from their injury. Many workers who don't receive timely treatment or their treatment outcomes are confounded by a return to work program that runs in counter purposes. So many cases where the return to work is premature and doesn't allow for adequate recovery. And that's usually around the lack of acceptance of ongoing musculoskeletal pain and limitations that the board feels is no longer their responsibility. So it was felt that premature return to work can delay recovery, and particularly for injured workers with chronic pain and mental health issues. And the fact that there were these kinds of misaligned and different perspectives on return to work meant that there was a degree of suspicion of each party, that each party was pursuing their own agenda. So from the healthcare provider's perspective, they felt that that agenda for the case managers was cost containment, or for the board was cost containment. And from the case manager's perspective, they felt that the healthcare provider's agenda was one of advocacy for their patients. So when there were these kinds of misaligned views of the appropriateness of return to work and the timeliness of return to work, what happened was that this led to a lack of collaborative action to resolve problems. and really also to an increase in adversarial relationships that cause stigma for injured workers and prolonged injury and delayed return to work. So here's how one healthcare provider specialist described it. So he's talking about a patient of his who's being sent back to work. I think she's going to fail. I think she's going to have a setback, but I feel that my hands are tied because the WSIB specialist said that this should be done. In the end, this person who recommended this has no plans on ever seeing this person again or reassessing them. Each time you put someone back and it's unsuccessful, then that actually complicates things and makes it even less likely that they'll return to work successfully down the road. So the next issue that came up was one around not understanding the workers' compensation system. And we found that many healthcare providers didn't have a clear understanding of both the workers' compensation system, or really what their role should be within that system and within the return to work process. And this became particularly problematic when a claim was complicated. So they had questions like, well, how does the system work? Who makes decisions about this patient of mine? How should functional limitations be determined? And how should work-relatedness be determined? You know, do I have that role? And how am I supposed to do that within my office? What is done with the information that is provided to the Workers' Compensation Board? What is my role as a healthcare provider beyond just treating the patient? What does the patient do at work? What will the return to work plan look like? And what do I do as a healthcare provider when things go wrong, when there's not a success in the return to work? So one case manager, this is how she talked about it. A lot of times it's just understanding the nature of the job. They're not experts, so she's talking about healthcare providers. They haven't studied ergonomics, kinesiology, or done job demands analysis. Even just trying to get a basic understanding of certain jobs, and even then, because what's in writing and what actually happens on the floor are two different things. So, like I said, we generally did find that there was this kind of lack of understanding of how the system operated, and there were, of course, some exceptions. So we did speak to some allied healthcare providers, for example, occupational therapists, who had a very clear sense of how the system worked and the return to work process. And similarly, physicians like occupational health physicians and chronic pain specialists who were very regularly dealing with injured workers and with the Workers' Compensation Board, of course knew a lot more about the system and how it operated. But I guess generally speaking, for the general practitioners, there were sort of some pretty clear gaps in knowledge. And the view that there were gaps in knowledge was something that was really shared both by case managers and healthcare providers, meaning they both kind of agreed that, yeah, you know, healthcare providers don't always know that much about how the workers' compensation system operates. The consequences of this were that there was confusion about policies, procedures, decision-making, and this led to frustration on both the part of both the healthcare provider and the case manager. Some healthcare providers were unsure about how to best help their workers' compensation patients. Case managers reported mistakes and omissions that on forms and reports, and how that, you know, delayed the claim process. And you know, we felt that in some cases the healthcare providers really didn't realize that the potential impact on the injured worker claim when, let's say, there were mistakes and omissions on forms. So again, when there were gaps in information about how the system operated and who made decisions and how decisions were made, collaboration and joint decision making was much more difficult. And this became problematic when a claim was prolonged and complex. So the next thing I'd like to talk about relates to something we've termed system rigidity. And what I mean is that our study found that rules and procedures sometimes at the board level sometimes lacked the flexibility to accommodate the circumstances of workers with complex injuries and conditions. And this was manifested in a number of ways, which I'll now discuss. So the first one was around recovery guidelines related to certain conditions and injuries. And here is a former case manager from Ontario. So they say, if someone fractures their elbow, yes, we understand the healing time is 6 to 8 weeks. The cast is removed and they should be progressing. That's a benchmark. That doesn't necessarily mean everybody is going to heal the same way, but they'd rather make determinations on entitlement using those independent guidelines versus the doctor's specific medical opinion. So we heard that a rigid adherence to recovery guidelines was particularly problematic with mental health and chronic pain claims. And what ended up happening is when people didn't recover as expected, they didn't recover within those guidelines, this often led to interruptions in treatment. So their treatment might be cut off, or their benefits might be cut off, and of course this resulted in patient distress. Another form of system rigidity that was discussed was around the requirement for objective evidence. So we found that healthcare providers struggle to adhere to rules and procedures when these and the injured worker's condition are a poor fit. Many conditions have a significant subjective component, so pain, mental health, fatigue, and so we were told by healthcare providers there is no test. I cannot provide the case manager with objective evidence for some of these conditions. And there was a real frustration when these conditions were treated just like physical injuries. So this is a healthcare provider from BC. They say, throw the physical rule book out the window. It's not applicable to mental health. Start from scratch. Train your people. If there's mental health issue on the file and the physical issue, go on the mental health side, because the physical person, so this is the case manager who's trained in sort of physical injury, does not get it. That's just for me. I feel really strongly about it. I keep on saying a bone doesn't heal the same as the mind. So again, when healthcare providers were unable to provide this kind of objective evidence that was required by the board, that often resulted in adversarial relationships. So both adversarial relationships between the injured worker and the case manager, but also sometimes between the healthcare provider and the case manager. So what sometimes happened was the injured worker was not believed, so the veracity of the claim was called into question, and this led to injured worker stigma, which again became an additional barrier to healing and return to work for the injured worker. So obviously not just problematic for the injured worker, but really also problematic for the healthcare provider who now had this additional issue to deal with. So the next issue that was raised, again related to the system rigidity, was around forms. Like I said at the start, forms seem to work well when injuries were straightforward. But form-related problems were identified when healthcare providers tried to convey information to the Workers' Compensation Board about complex injuries and return-to-work problems. And I'll give you just two examples. So in Newfoundland and Labrador, the form that the healthcare provider has to fill out had these injury codes and symptom codes. So the healthcare provider would see their patient, would evaluate their patient, and then they would have to look at this form and say, okay, so what is this code for what they have, and what is the code for the symptoms they have? And so you can imagine how if somebody had a really complicated injury, or something with a gradual onset, or several different injuries, that this made filling out this form to be very, very problematic. Similarly, a different issue, but in British Columbia, we were told about the electronic forms, and that there were word limits associated with some of the entries. And so here's how one BC healthcare provider described it. If someone has been in a major accident or a major work injury and has had lots of treatment or been admitted to hospital with surgery, it's really hard to get all that in there. You're only allowed 250 characters. So if you want to start really trying to give WCB, I want to do a good job for them and tell them that this guy has done this, he's having pain here now, and seems to be getting depressed, and it'll say out of characters. So as you can probably see, there were these challenges related to the forms of conveying a complete picture of a complex situation on some of these existing forms. So the next thing that I would like to talk about is around communication challenges. So communication challenges were identified as a barrier to effective collaboration, and the problems seem to go both ways. And what I mean by that is we were told by case managers that healthcare providers were not great at returning calls. They didn't always fill in forms properly, nor did they fill them out promptly. They didn't provide enough information about the worker's condition, or they didn't provide the right kind of information. Healthcare providers, on the other hand, also said to us that sometimes case managers were not great at keeping healthcare providers in the loop about decision making, or not telling them how decisions were made or even what kind of decisions have been made. They were not always forthcoming in discussions around return to work planning. And sometimes healthcare providers weren't told if their patient was being referred to other healthcare providers or to a treatment center or to an evaluation center. So some of these communication problems were due to kind of logistical issues, right? So things like when the case manager called during the day, the healthcare provider was seeing patients, so of course they couldn't take the call. And then when the healthcare provider tried to call them, well, it was at the end of the day, and so the case manager was gone, and so there was just a lot of voice messages and phone tags. So certainly those kinds of issues existed. But then there were also those other issues that I've discussed earlier in the presentation as well. One of the things that healthcare providers raised with us is frustrations that arose when they had to communicate with non-medically trained personnel. And again, this is usually around complicated claims. So here's how one healthcare provider in Ontario, she told us about the situation she had. In the past, when I've talked to a case manager, they just don't really seem to understand what I'm talking about. I actually had a situation where a patient had a cervical, like a neck, cervical spine problem. And for some reason, they had requested records. And there was something in the patient's chart about cervical dysplasia, like of your cervix, the female genital organ. And they said that she wasn't covered because she had a pre-existing condition, which is completely ridiculous. And then I had to spend hours sorting this out. So as you can see, communication difficulties led to delays in decision making and also sometimes delayed in treatment as some of these issues had to be sorted out. And one of the things that we saw was that, that participants told us about was that sometimes injured workers were used as a kind of go-between between the case manager and the healthcare provider, and sometimes between the healthcare provider and an employer, or the case manager and the employer. And this was not always appropriate or ideal. So, for example, it wasn't appropriate sometimes because if the case manager was asking the injured worker to get their healthcare provider to send something in, the injured worker doesn't always feel like they can speak up and have that sort of control over their healthcare provider. And certainly injured workers who are on medication might not understand some of the treatment recommendations, and so this information was then being given secondhand to either case managers or to healthcare providers, which of course could result in misunderstandings and incorrect information being conveyed. So the last sort of major theme that I wanted to discuss was around the exclusion of healthcare providers from the workers' compensation system. So I want to first of all just read you this quote, which is quite long, but I think very illustrative. So this is a specialist in Ontario. He says, "The communication is very, very important. The physicians who are treating the patients, I think that lack of engagement is a big problem. There should be a note sent to the physician and to the specialist of the patient saying, we are sending this patient to the specialty clinic. I don't think that happens, and I think that creates distrust." So the interviewer asks, distrust on whose part? On the physician's part, if your patient is going places that you have no control of where they're going, it feels very bad. You feel like a bad doctor. You feel like you're not treating your patient well. And then it encourages a lack of responsibility and engaging of the physician. So think about it. You get your patient and he comes to you and he says, oh, I have this appointment to go here. And the physician doesn't know anything about it and it's just arranged for him. The physician will just throw up his arms and say, okay, well, if that's what you're doing, okay, I guess. And then you can imagine that he sort of feels like, well, I guess I'm not involved. So we found that when healthcare providers talk to us about their experiences, there were kind of different ways where they were, and some of these were little ways, that they were alienated from the system and that they themselves sort of became removed from the system. And so some of these I've already discussed. Things like repeated failed communication attempts. So if you tried calling the case manager a bunch of times and leaving messages and you don't get a call back, that's going to make it probably less likely for you to continue doing that. Lack of understanding of the healthcare provider's role in the system. Different views on return to work, on its timing and appropriateness. These feelings of that the system is very rigid and doesn't work for the patient that they're seeing. Feelings that the workers' compensation decision maker is predominantly concerned with cost containment. And then one that I wanted to spend a little bit more time focused on, because I haven't talked about it yet, was the use of internal medical consultants. So these are healthcare providers typically, so doctors or other types of specialists who are connected to the board, often working within the board, and their role is to provide guidance, medical guidance to help with decision making around a claim. And they often help case managers with understanding of medical information. They're a source of really quick access to case managers, so we heard that they were very useful because often the case managers could just call them up or go down to see them and quickly get an answer to a medical question. And in some cases, they also helped bridge the gap between the board and external healthcare providers, so like the treating healthcare provider. We heard specifically in BC and in Manitoba that some healthcare providers said that they actually use the internal medical consultants as a resource. So they would sometimes, if they were having trouble with you know, a return to work, or if they wanted just to talk to somebody else about a treatment path they were thinking about, they would call the internal medical consultant and have a discussion with them about it. However, we also found that many healthcare providers really didn't know anything about internal medical consultants or what role they played at the Workers' Compensation Board. And we found that in all provinces there were some healthcare providers that were very critical of the use of internal medical consultants. And the reason for that was that, in part, was that internal medical consultants were sometimes used to overturn external healthcare provider decisions, so the decisions that were made by the treating healthcare provider. And so here's how one specialist described it. The bottom line is it's the medical advisor's opinion that counts, not necessarily the treating physician or the specialist that may know the patient better, but the internal decision within the WCB trumps even multiple care providers sharing the same concern. That's been my experience. So the literature on on return to work has focused on collaboration with the various stakeholders in the system and healthcare provider involvement in return to work. But we found that there were many factors that really helped to alienate healthcare providers from the workers' compensation process. And this diagram here really describes how we saw a cycle of alienation developing during interactions between healthcare providers and workers' compensation decision makers. So you can really kind of enter this diagram anywhere, but let's start with the healthcare provider disengages from the system. Well, if the healthcare provider is not engaged, they're not providing the information that the case manager needs, well, then that healthcare provider is really kept out of the loop. So that the case manager may go to then go to an internal medical consultant to help make the decision on the claim and really rely heavily on those internal medical consultants. So when the healthcare provider knows, well, I'm not being consulted, my decision is being overturned, this results in an adversarial relationship. And again, as people become a bit more disengaged from the system, there's a lack of system understanding and a poor communication, and in some cases really a reluctance to treat workers' compensation patients. And again, we see this disengagement of the healthcare providers from the system. And sort of around and around it goes. So I want to end just by talking a little bit about the implications and recommendations from the study, and because I want to give us some time to have a discussion after the presentation. So some of these recommendations come directly from the healthcare providers that we interviewed. The first one is just around the need for clarity around the role that healthcare providers should have in the workers' compensation system and in the return to work process. One of the things that I mentioned at the start of the presentation was, and I haven't talked about here at all, but it was about the scan we did looking at resources that had been developed for healthcare providers on return to work and on their role in workers' compensation. And one of the things that we found during the scan, and we've actually written a paper about it that will be sent out for publication shortly, is one of the things we found was that there was a lot of vagueness about what healthcare providers were told about their role. And even sometimes within the same jurisdiction, there were conflicting messages about what their role should be. So, you know, are they just meant to be dealing with functional limitations and determining them? Are they meant to have a really active involvement in return to work? Should they be talking to the employer? So there was a lot of sort of inconsistency around that. And so we felt that what really was needed was a full discussion at the Workers' Compensation Board about what should the role be. And then similarly, a discussion amongst healthcare providers about what should be, and then ideally a discussion with both of those groups and a kind of consensus about, well, what should healthcare providers be doing within these systems. Next, we feel that there really needs to be more information about the workers' compensation system available to healthcare providers. And of course, not every healthcare provider is going to want to read up about the ins and outs of the workers' compensation system. But I feel like there's opportunities to provide this information so that it's readily available if a healthcare provider does want to know about it, does want to know how decisions are made, does want to know, you know, what is sort of the best evidence around return to work and so on. And one way to do that is in the healthcare provider sections of this website, of healthcare provider section of the websites of the workers' compensation boards. And again, during that first phase of the project, we reviewed all the websites, and you know, some of them are amazing. They provide a wealth of information. Others, very, very scant information, very vague information about, you know, what is your role? Well, your role is just to support return to work. But really, what does that mean? What does it mean to support return to work? So just some very clear guidance on the role, and also on how the system the systems in each of the provinces operate. Other ideas given by healthcare providers was really to target medical schools and medical training so that there is, you know, there's this captive audience, and so when students are going through medical school, to really make an effort to have occupational health and disability management on the agenda, and to give healthcare providers some information about the workers' compensation system. And then other ideas were things like short courses for continuing medical education credits and mobile applications so that people can access information very quickly on their phones. We also felt that, you know, not everyone has the same sort of capacity for return to work planning and dealing with some of these complex injuries and claims. And one of the things that we did in the study, which was very insightful, was interview healthcare providers who worked in walk-in clinics and in emergency rooms, so just a handful of healthcare providers. But it became obvious to us, and it was obvious to those healthcare providers, that they were really not in a position to do any sort of long-term management of workers' compensation claims, right? So they couldn't be involved in any sort of full way in helping people get back to work. So how about having an option on forms that allows healthcare providers either to get support for return to work planning and for getting somebody to call them and really help them through it, or even to opt out of return to work planning, saying, I can't be involved in this. I'm not the right kind of healthcare provider to do this. And we know that in BC that actually they do have that option on the forms, but it's certainly not something that is available in all the provinces. Next, we really feel that there needs to be a focus on how to deal with complex conditions and with patients in circumstances where they have a prolonged and complicated claim. Some of this involves increasing training for case managers related to mental health and chronic pain, and really taking steps to make sure that case managers are not further stigmatizing injured workers when they file those sorts of claims. We also like this idea that was introduced by Seeing and McKechnie in 2011, which they called flexibility, not procedural rigidity. So what I mean by that is, of course, there's going to be rules and regulations within the board about how certain things are done, and they're large organizations. But we really heard loudly in the study that there needs to be a degree of flexibility, especially around some of those complicated and prolonged injury claims, where there are mental health overlays, where there are chronic pain issues, where there may be repeated failed return to work attempts. So there really needs to be some flexibility around that. And one way that I've already mentioned was around these recovery timelines. And so one of the ideas was, when healing extends beyond these recovery timelines, one approach might be to offer greater support to those workers, provide them with mental health counseling. So some of the healthcare providers interviewed felt really passionately about this. When the recovery doesn't go as planned, don't cut people off, don't cut off their treatment, because that just makes things worse. Rather, offer them some further support and see how we could work together to get people recovered and treated in a more effective way. And then again, just that issue of form flexibility, which I think is a relatively easy issue to fix, where there are options that healthcare providers are able to fully describe what is happening with each of their with their patients and the circumstances they find themselves in. And then finally, we think that when case managers talked about these internal medical consultants, they really seem to be a great resource for case managers, and that really shouldn't be discounted. They had this resource where people could provide them with clarification and so on. But we think that these internal medical consultants should be used to communicate and work collaboratively with the treating healthcare provider. And really that should be their role as a kind of bridging the gap person between the board and the treating healthcare provider. And so their role should be that, and not the overturning of medical decisions that the treating medical provider has made. So I'm going to stop it here. I will just quickly just make a few kind of administrative points, which is that, and Tanya mentioned this, that we're almost finished the final report, which it has to go back to the funder, and we will be done that within the next couple of weeks, and then once that happens, the report can be circulated. It has a lot more information. This was a relatively large study with lots and lots of data because the interviews were quite long and rich, and so the report has a lot more information and details and examples and so on. So so if you think that you would be interested, please feel free either to contact Tanya, or my contact information is there, and you can certainly contact me and I could share this report with you, and some of the other pieces that I just briefly mentioned, the resource scan that I mentioned, and we also have another paper related specifically to mental health, which also will be coming out and will be ready for publication in the next couple of weeks. So in the next sort of 1 to 2 months, we should be able to circulate some more information and findings from the study. So thank you very much for listening, and I look forward to your questions.
Wonderful. Thank you very much. Let's see. Let's go ahead and dive right in. We had a question. There was a previous question just around if there were registered psychologists within the study?
Yeah, so again, we didn't interview, as you probably remember, that we didn't interview that many, we sort of called those allied healthcare providers, just to give them a name for the group. But yes, we did interview some psychologists in that group as well.
Okay. And then someone was inquiring as to, within the questionnaire, was there any addressing for the more complex patients, any discussion around the objectivity of the physicians when they've had such a long-term relationship with patients, and that maybe there, might be not as much objectivity because they want to do what's good for the worker versus medically, or anything along those lines?
So just to clarify, so it wasn't a questionnaire. There were it was we had an interview guide which had all sorts of mostly open-ended questions about their experience treating injured workers, their experience interacting with the board, and we had specific questions about what made things more difficult and what was sort of a straightforward, what made things go well and what made things go poorly. So I guess the issues around some of these complex injuries and claims came up when people were talking about, well, what made things more difficult, and what, and I don't think they were saying these people with these complex claims make things difficult, but it was rather the kind of fit between those claims and then the workers' compensation system and some of the policies and procedures that I described during the presentation. In terms of the question of objectivity, I mean, my response to that is no one is ever objective, right? We all have our subjective experiences, and certainly it was very interesting because this issue of objectivity came up a lot in our discussions with the healthcare providers and with the case managers. So we were really interested because when case managers spoke about these internal medical consultants, they often talked about them as being objective, that they were giving them an objective medical opinion. Now, stepping back a little bit, I would argue that they have their own biases and subjectivities as well. For example, they're first of all being paid for, their salaries being paid for by the Workers' Compensation Board. They're interacting very regularly and closely with the case managers, right? So that, of course, that might introduce some, subjectivity and biases, and then, and of course, with the healthcare providers, of course, they may have long-term patients, and certainly some of the case managers talked about is, their role is to be advocates for their patients. But really what I felt they meant by that when they described what they meant by advocacy, it wasn't, I'll just do whatever my patient tells me. It's, I will do what I feel is best for my patient. Knowing this person, knowing who they are, and and you know, their background and knowing their health history, I will do what is best for that patient. So yeah, I'm not sure if that completely answers that question, but just those are, I guess, my thoughts about that issue of objectivity.
Wonderful. There was a question if you looked into it, or if the physicians mentioned it, which provinces out of the ones that you were included in the interviews had the most informative websites in education in med schools and medical associations around the workers' compensation process?
Oh, you know what, that is a very good question, and I don't have that information on the tip of my tongue. What I would suggest, if the person who's interested in that, is in a couple of weeks I could send you the paper we wrote around the resources that were made for healthcare providers on return to work and workers' compensation. It has a lot more detail about that issue and sort of what are the gaps in that information and so on. I know that out of the study, certainly BC has a very has a good website. They've got a lot of information on their website, very clear information, easy to access information. And Ontario also has a pretty good website which has a lot of information. Sometimes, like I said, sort of towards the end of the presentation, though, it's not necessarily. So there's information, but again, when there's a discussion about the role of the healthcare provider, what we end up hearing or seeing in some of these materials is that there's a lot of vagueness around the language used. So things like, you know, you should support return to work. You should get forms in promptly. So those types of terms are very open to interpretation, right? So prompt for me might be completely different than prompt for another person. Supporting, I mean, what does that mean in practice? Does that mean I'm supposed to contact their employer? Does that mean I should go, you know, go into the workplace? Does that mean I should, I don't know, help them communicate with the board? So I think just across the board, there really needs to be a bit more specific information about some of those issues, just about what the role should be. And I guess before that happens, there really needs to be a discussion and some form of consensus about what that role should be.
Very good. Let's see. We have another question. Just I think this to some extent is related just to the communication piece and the importance of that communication between the healthcare professional and the claim manager. But someone wondering, you indicated that healthcare professionals through this interview process felt that premature return to work can delay recovery. However, the Canadian Medical Association policy has done a lot of research on prolonged absence being detrimental for one's mental, physical, and social well-being. So just kind of wondering if that discussion was commented on, or how much it was discussed within those interviews, if the healthcare professionals understood their, I guess this says that they have an onus to work with the claim manager to understand those demands within the workplace prior to making recommendations of diagnosis.
Yes, I guess there's a couple of things that you're pointing to. So I think the healthcare providers didn't talk a lot about the guidelines. Like I said, they did talk about the importance of return to work, and I tried to convey that. I don't know if I did it strongly enough, but certainly there was a lot of support for return to work. I mean, we didn't hear anyone say, I don't think, oh yeah, no, like just, you know, just bed rest, right? You know, people were, the participants, the healthcare providers that we talked to, certainly understood that there were many benefits to return to work, that getting people back to work. But I guess there was a little bit more of a, like I said, more of a nuanced understanding that return to work is not always good for workers. It isn't in all cases good for workers. There's no kind of a blanket statement that can be applied, because there are workers who have injuries that really, if they go back to work too early, I'm speaking from the perspective of the healthcare provider and what they said, that it will, in the end, ultimately delay their recovery and delay a successful return to work, which again is not good for their health. And there are certain workplaces where, there are either a toxic environment, this came up around mental health, the environment caused the mental health condition and it was unchanged, and that worker was being expected to go back to that workplace. Well, that isn't going to be good for that worker. So I guess I was just trying to convey, or maybe they were trying to convey, that of course return to work is good in many, many, many circumstances, but there can't be this blanket statement that it's always good for everyone in all circumstances. And they gave many examples of when actually you need people to recover, and you need people need to be, again, this came up a lot in with mental health. One of the interviews with a healthcare provider who was talking about a person with a mental health condition who could barely get themselves out of bed, and they said, we need to work on getting those people back to living and just functioning within their non-work life before they can make an attempt to return to work. So that was his perspective, and his feeling was that if you push them back too early, it's just going to be detrimental in the long term.
Very good. I don't have any further questions at this time. Actually, one just came up. We'll do one more, and then I think we'll wrap it up. So what are the recommendations for increasing collaboration or relationship development to facilitate this kind of recovery and return to work?
So I really like the idea of, what I mentioned at the very end about using the internal medical consultants as a kind of a go-between the board and the treating physician, in part because we heard from treating physicians that they much prefer to speak to somebody with medical training. And I think, like I said, in Manitoba and in BC, we did see in some circumstances that those consultants were being used as a kind of resource, and I feel like that would be a really positive change, that if healthcare providers saw those internal medical consultants, and if in fact those internal medical consultants were a resource for healthcare providers to get them more involved within the system and more kind of familiar with the system, and allow them to have a communication about what works best and what can help a person with a particular condition, I think that would be very, very positive. I think there's a lot of little things around that. I mean, I don't want to go through all of them again because some of them I've already mentioned, but basic things like with the forms and making them more friendly, and for people who need to write more, who need to describe a complicated claim or situation, having more information on the website that can be easily accessible and in one place. So it was interesting because when we were doing that scan, one of the things we found was that there's a lot of really great information on the websites, on many of the workers' compensation websites, but sometimes they're in a different section. They're on like the injured worker section, or they're in some other kind of policy section. And so when you think about it from a healthcare provider perspective, where they have to get this information quickly, it needs to be on the tip of their fingertips, they're not going to go looking through the entire website to find that information. So just make it in one spot. And then I also just feel very strongly about trying to get some of this stuff into medical training, where the students are there and they're going through training anyway. So provide them with some of some information about disability management and working with the board in that in each of the provinces. So, you know, if it's a BC medical school, provide them information of what it's like to just something very straightforward about the compensation process and who makes decisions and what their role is in decision making and so on.
Wonderful. I think those are some really good recommendations. Thank you very much, Agnieszka, for facilitating this conversation and for giving us a glimpse into the views of healthcare professionals. I think it's a really interesting place to start the conversation from, and that it adds a lot to the whole conversation around getting people back to work.
Great, thank you. It was a pleasure.